Ladies and gentlemen, dear colleagues, we are here at the EAU 25 in Madrid. I'm Dr. Giancarlo Marra, Chief Editor of the UROONCO platform. We are here at the EAU TV with Professor Philip Cornford from the University of Liverpool, who is also Chair of EAU Guidelines on Prostate Cancer. Welcome and thank you for being with us today.
Thank you very much. Nice to be here.
So, Friday there was the press release and we had some changes within the guidelines, of course, some updates. We won't have time to discuss all the updates because there were many, but we will focus on some of them. I think we can start with prostate biopsies. Hot topic, always hot topic, very common procedure. There were some changes in terms of where we should take the biopsies, meaning systematic or perilesional biopsies. Can you tell us a bit more about this update?
So we have seen increasingly that if you take a targeted biopsy and then a perilesional sampling, because you're probably not quite as good at doing your target as you think you are, and therefore even with fusion biopsies, you still run a risk of missing a tumour, you can then get a precise diagnosis of exactly what is the prostate is holding. And if you avoid doing systematic biopsies, then you can avoid identifying insignificant, largely ISUP grade group 1 prostate cancer that we're not really interested in knowing. The difficulty is that if you go for trying to sample the prostate, you see an extra 20% of insignificant cancer, but without finding any disease that was going to alter what you do in terms of management and planning.
Yes, it is going to cause patient distress and perfect. So the umbra-penumbra concept, where we should focus more compared to going contralaterally, for example, or distant from the lesion, not to find insignificant disease.
I mean, I think it's important that you take enough cores from the biopsy. People started off and they only took 3 from the focal lesion. I don't think that's enough. You want 4, minimum 5 ideally, and then you want to sample that area for about 5 millimeters around the outside of the lesion in order to make sure that you identify any aggressive cancer that might be present.
Yes, also because our precision in doing biopsies, even if we are good, is not 100%. So if we target very well all the area, the concept is we are going to get the cancer if there is cancer. Perfect. So another question where I think there was not a major change in terms of guidelines this year, but 3 trials came out. Another trial is going to be presented here at the EAU, is the concept of transperineal versus transrectal biopsy. So we know the results of the PREVENT trial, which was actually the one with the largest sample size, showed basically there are no differences in terms of infection, but on the one hand, we had transperineal biopsies without antibiotics, whereas on the other hand, the patient had to do a rectal swab, the culture needed to be read, and the antibiotic treatment needed to be adjusted. So patient doing a test, someone having to look at the test, read the results, and eventually change the treatment. How was this reflected within the guidelines? What are now the current recommendations?
So our recommendations are still to stick with transperineal biopsy. The interesting thing about PREVENT is that 23% of people actually had to change their antibiotics based upon the rectal swab. And although it would be possible, if you were prepared to swab everybody and look for people who were no longer sensitive to the standard antibiotics we use, it would be possible to still do transrectal safely. It is also true that many people are not doing rectal swabs, and therefore they run a real risk that the antibiotics they give are not going to be the appropriate ones for the organisms that are present. If you do really want to do transrectal and you're prepared to do a transrectal swab and you are prepared to change antibiotics, you could still carry on doing a transrectal biopsy, but it's a lot of extra effort and there's no clear advantage for it. So if you have a patient who needs a biopsy, you are better to minimize the number of cores, as we were talking about earlier, by just targeting the lesion and doing sampling. You don't need to give antibiotics, because that study again showed that no antibiotics was just as good as selective. And of course, we worry about antibiotic stewardship, and we also worry about the risks of ciprofloxacin. There's no doubt a risk of tendinitis. There is clear evidence from the EMA that you need to be careful about using this for prophylaxis. And here we are in transrectal biopsy. That is the most common thing that urologists use. And I think that will be difficult to justify if a patient had an adverse consequence when you could have done something different.
Yes, and so the less, the better actually, in terms of antibiotics, and these were WHO recommendation giving less antibiotics, but also in terms of cost and organization, because if you are doing 2 biopsies per month, is one thing. If you are a high volume center, for example, you are doing 20 per week, the risk is to increase a lot costs and have organizational issues. Okay.
And I think that those groups that do it fairly rarely, because even if you give antibiotics, your chance of infection is fairly small, and so you go a whole year because you only do 2 a month. You might go a whole year without getting any infections, and you think, oh well, I don't have a problem. You just aren't really doing enough to demonstrate the problem that will happen. That problem will come back and get you.
Yeah, of course. That's the other problem, is that people getting this kind of antibiotics are then not followed up on saying if they are resistant to something or our infection later on. Okay, thank you. Thank you very much. And the last question I saw there were some changes and this I think can be a good link from the first question in terms of I'm biopsying more towards the positive area on imaging. So I'm going to focus on where we likely have the cancer, and this may lead to change in the diagnosis of the same disease that was then previously diagnosed with systematic biopsy. And this year the guidelines actually split the intermediate risk disease in 2 groups. What are the main reasons and why was this change adopted this year?
Okay, so I think that we have seen in clinical practice for some time that people think about low risk and high risk intermediate disease. People have already begun to think about it, and we worry that MR targeted biopsies leads to an increase in grade. So lots of people who would have been ISUP grade group 1 suddenly become ISUP grade group 2. They've got a tiny amount of 4 on that targeted biopsy. And we don't want to see the same over-treatment that we saw with the introduction of PSA. We know that surveillance is probably better for a subgroup. And if we can separate out that group of low intermediate risk tumours, then they might well be patients who are suitable for surveillance rather than immediate treatment. They're probably a little bit more likely to go on to need some treatment in the future, but even those patients, many of them will be treatment-free 5 and 10 years after diagnosis.
Yes, there are recently more and more evidence coming on active surveillance for intermediate risk disease. So actually, these are not intermediate risk disease, but as you said, are low intermediate risk disease. They are 3+4. They are not 4+3 disease. Yes. So since this year in the guidelines, this difference is made clear to guide also your clinical decision making, because there are groups that can be managed differently.
Absolutely, and it makes us not think about all of the Gleason 7s as the same thing, and makes us understand that we have got a low risk group here that will have much better prognosis. Okay,
so important and I think very interesting changes with relevant clinical implication. Thank you very much for discussing this with us today, for being here, and thank you very much to everyone for listening.